of this class. So this is absolutely 7th of the September. Just make a date in your calendar. 7th September, I'm going to conduct mega mock test. 7th September, it is on Sunday, right? Most of my classes are on Sunday, so everybody can join. Every Sunday we are arranging the mock test, but now onwards, every Sunday we will we will announce one gift just to motivate the people, right? This is first time. And what would be the gift? This is a personalized gift from the medical MCQ for all. It is in terms of getting the materials. Gift from the medical MCQ for all. And it could be hard copy to your doorstep in India. Out of India, we also deliver, but we need to pay little courier charge. Otherwise, in India, absolutely free. You don't need to pay even single penny for courier. So absolutely free. And or someone wants a 1 month subscription, that is absolutely almost free, right? So you don't need to spend a single penny. This is just to motivate you guys. See, right? You can have it by your own as well. This book and website, it's not that costly, but still I would like to motivate you. I would like to crack your exam in a first go. So we are coming up with the various interesting ideas which will going to eventually help you. So you don't miss this class. Those who feel that I have absolutely prepared for exam, I have a good preparation now, right? And I can give any exam. So just write this seventh September mock test on Sunday, right? As I told you, we'll produce one nice gift. What would be the criteria of exam? Assessment of the mock test, whatever the mock test you give online through our website, right? We will do the assessment after the mock test. What includes in the mock test? Exactly like the exam, how you supposed to appear in the exam. 150 MCQ, 3.5 hours time duration, 65% is passing score. Sometimes they may ask for 60%. I keep it little higher just to get you the idea where are you standing, right? And we'll give the gift to not all the candidate who has highest score, right? And that will be announced properly, and I will produce it properly. So try to do it. Those who have little financial constraint, right, getting this website book absolutely free, 100% free. But you should push yourself bit hard, right? And exam can be given online via medicalmcq4all.com website, right? My manager Pallavi will going to make some voice notes, so you just go through it and she will guide you, right? And test time would be anytime, 7th September, anytime. So in within 24 hours you can give the exam anytime, right? But only condition is that like exam you should finish it in 3.5 hours. Once you are out, I mean, computer will lock in 3. Once you start the exam, you have to finish the exam. So choose the time, whatever the best time you feel, you choose the proper time, right? So you have 24 hours, means 7th of the September, right? Whole 24 hours, you give it in afternoon, morning, evening, night, whatever your time. But once you are in computer, you are like absolutely finish the exam. So it's absolutely designed in a such a way that you are going to give the exam, right? So this is what the thing is. So this is special newly first time announcement. This is how you can see on the website, right? So I created it already class, right? But it will be activated on the 7th. So 7th of the ninth mock test, 150 questions, 65% passing, 3.5 to 4 hours time, right? And it will end on the same day, 7th of the September start and 7th of the September, 12 o'clock night it will close, right? And I created it today, so published date is today's 2nd of the September, right? So you just keep in mind, and I strongly recommend you give it, strongly recommend you give it, right? And by this, right, you get to know where are you standing exactly. So that is one important announcement with little exciting news of free book and subscription. Dr. Aarti is our consultant pediatrician, taking lots of lecture with me for more than 5 years. Dr. Maddie is a very popular coach amongst our community PROMETRIC. She is a brilliant speaker and internal medicine and excellent cardiology endocrinology she is taking. Dr. Ankit is DNB, means he is a super specialist guy with gastroenterology, and excellent speaker as well. Dr. Shikha Garg is a consultant gynecologist now based at Dubai with Aster Clinic downtown. So she's in our team, and along with that, we have newly three faces joined. Dr. Mariam, Dr. Sonal Shah. She's a consultant emergency physician from reputed institute from India. She's from New York. Mariam Hilad, she's taking neurology usually. So apart from that, we have other teams like Dr. uh, Deepali, Dr. Anjali, Dr. Meghna, and Dr. Pallavi is our backbone. So she is like the one who is coordinating with you. She is our support manager. So Pallavi is also excellently doing well in our team. Right. So these are the data flow. We also do the data flow as well. So anybody wants data flow, license transfer, anything, feel free to contact us. Mock test, as I told you, I mean, we added lots of mock test on our website. So you just go and utilize it, right? Material is enough. There are many questions people are coming and asking me, sir, this website is enough, right? Is there any other things which I need to do? Is it, I mean, they don't have trust. Believe me, for you, it's just the website. But I spend my half life creating this system globally. So if you sincerely prepare for 2 to 3 months, I can guarantee you, assure you, you will 100% pass. See, it's all about the preparation, right? And you have like absolutely clear cut MCQs, subject wise pictures, ECGs. You ask anyone, believe me, you ask anyone those who are using it, not one, two, there are hundreds of people joining every month and almost 9,000 doctors already enrolled since 2012. So it's a proven now, right? So you don't need to struggle much. You just need to focus on your preparation, how to prepare, what to prepare, and in case of any queries, just contact us, right? These are the various packages. This is one of the best and most popular amongst this all, right? Is 40 hours of coaching, right? 3 month subscription, which is supposed to be around 900 to 10,000 USD, which reduced to 350 only. So almost you get 600 USD discount is quite big. In Indian rupees, it is 60,000, close to 50 to 60,000. So anyway, this is what the base thing is. So you can inquire later on, but we recommend this overall. And you get hundreds of things complimentary along with this. And last but not the least, before we jump to our main class, right? Those who have not subscribed the medical MCQ for all, right? You subscribe it. There are hundreds of videos are there. Fortunately, is a free access. If you see one video per day, believe me, one video, only one video per day, at least your 90% course is covered within 3 months. Only just one video a day. If you don't get any time while traveling, going hospital, coming hospital, right, surfing the Instagram, so stop Instagram for 2 months. You see it, but just 5 10 minutes. Don't waste time, hours and hours on Insta. It will not produce anything. It's useless, right? It will not going to help you. But if you score well, you have bright future in Middle East, right? So this is what I'm telling you from my heart, right? So this is what, so, and we have mobile applications as well on Android and iPhone. So those who did not download it, you can completely surf whole the website from Android and from Apple iPhone as well. This is the same logo on both and same name, Medical MCQ for all, Play Store, Android as well as Play Store in Apple. So you can completely surf the whole website from the mobile, right? From laptop as well as from mobile application. You just need to download like you're downloading WhatsApp. That's it. So this is what the thing is, right? So that's all. I mean, let's move to the main stem of the things. What we gonna cover today is methacholine test or asthma related things, HIV and pneumonia, PCP, pneumonia organism, active versus latent tuberculosis treatment, adverse effect, AKTs, lung cancer, COP65, typical atypical pneumonia, exudate versus transudate, CT pulmonary angiogram, VQ scan, blah blah, long list of pulmonary embolism, and lot more. So this is absolutely high yield questions I am trying to prepare. It is not every time given in the books, but I tried my level best whole the week to produce best of the best slide which is easily understandable and readable and the things. So let's start with these things. You check your own score. You don't need to show me. You check your own score, right? How many questions you solved and what's your score. So first questions in front of a screen. 15-year-old boy comes to the office because of occasional shortness of breath every few weeks. Currently, he feels well. He uses no medication and denies any other medical problems. His vital stables and chest examination is normal. Which of the following is a single most diagnostic test at this point of time? These all are the frequently asked questions in the exam and past papers, right? So I did lots of exercise from many years and years and produced these slides. So every slide is important, every word is important. So options are peak expiratory flow, increase in FeV1 with albuterol, diffuse capacity of carbon monoxide, more than 20% decrease in FeV1 with use of methacholine, increase alveolar arterial oxygen difference, increase in the FVC with albuterol. Take your own time. This is absolutely a this interactive session, so I will not speak alone. I will ask the name and you also speak with me. So those who are joining me the first time, I have given the trial. MCQ means multiple choice question. You need to know three things. Ask yourself three things. What is the diagnosis? How you gonna investigate? And what is the treatment? So in any exam globally, USMLE, PLAB, Australian Medical Council, Irish Board, Canadian Board, they ask three questions. What is the diagnosis? So you need to know the diagnosis of this scenario. Once you make a diagnosis, you're supposed to know how you're gonna investigate and how you're supposed to treat this patient. If you know these three things, you are master. Believe me, you are master in 1 month. Master of any MCQ in 1 month, you are unstoppable. Believe me, right? So we need to make a diagnosis. So you need to think of the diagnosis. Everything is in front of you. Yes, your time starts now. You go ahead. Anyone openly can interact, comment, discuss, all open. Don't shy. It's absolutely a learning platform. So what's the diagnosis or likely diagnosis?
Bronchial.
Yes, please. Yes.
It's bronchial asthma.
Sorry.
The
What is the
diagnosis
diagnosis?
is
Mild intermittent.
diagnosed
Yeah, yeah, you go ahead. No problem.
bronch.
Sir, mild intermittent
Bronchial.
asthma.
Okay, so asthma, basically asthma, mild intermittent or mild asthma. Okay, fine. Fair enough. Now, what is the condition of the patient? What they exactly ask? What they ask? Three questions they ask usually, right? I told you diagnosis, investigation, treatment. So they are asking the most diagnostic test at this time. So this time, patient is in very much severe asthma, yes or no? First, identify. Yes or no?
No. No, he
No.
says no.
No.
No,
No.
right. See, listen.
No.
15 years old boy comes to the office because of occasional, not now, occasional, sometime. Shortness of breath every few weeks, every few weeks. So few weeks he has shortness of breath, then he's normal, fine, then he is as occasional, right? So every few weeks, not even every week, every few weeks he has occasional, and that is occasional shortness of breath. Currently he feels well. Currently at present, when boy coming to your office, he is normal. He uses no medication. He is not on any bronchodilator. He denies any other medical problems. His vitals are stable. Do you mean by vital? Temperature, pulse, BP, respiratory rate, SpO2, blah blah. It's all normal. Vitals are normal or stable. Chest examination is also normal. So now he has no rhonchi, no crepitation, nothing, no abnormal foreign sound, absolutely fine. So he has a mild asthma, mild asthma. So what do you think? What do you think? What now they asking is which of the following is most diagnostic test, right? This is your clinical diagnosis that he suspected have asthma. So by doing which test, you can say that, okay, fine, this is absolutely asthma. So now you apply your brain how, right? A, B, C, D, E, F. What is the best test by doing which you can confirm that this patient is an asthmatic patient?
Increase
Yes,
in
sorry. You can speak loudly. Don't worry about right or wrong. I'm also learning for last 25 years. Don't worry.
increase in FEV1 with albuterol,
In
short-acting bronchodilators.
Okay, so increase in FeV1 with albuterol. Okay, fine. This is your
Um,
answer. Fair enough. Fair enough. So, do you think giving the albuterol will increase the FEV1 in this patient when he is
No.
currently
Won't
asymptomatic?
increase.
Current is
Won't
normal.
increase.
Current is like you and me.
It's
So
normal,
if
yes.
you and me will take albuterol today, tomorrow morning, and we do the FEV1, pre-albuterol and post-albuterol, do you think there is an increase in FEV1 in a normal person or near normal person?
No.
No. So your answer is gone, right? So this is not the answer, right? In a normal, if it is a asthmatic patient, right now patient is has a bilateral wheeze, increased respiratory rate, classical things, little hypoxia. Answer is yes, increase FEV1 with albuterol, but those patients who are symptomatic, this patient is not symptomatic. Right now he feels well, means not symptomatic. Everything is problem, no comorbidity, right? His chest is absolutely normal and clear, his vitals are stable. So reasonably, this is a good patient, right? So now what test you would do perform the second, right?
P,
Increase FEV1 with albuterol is gone.
PE.
Our our job is not just to get the answer. Exclude A, B, C, D, E. Why this not? Why this not? Why this not? That is also job. And if you cultivate this, you are expert. Yes. What is the next option?
Peak expiratory flow rate.
Sorry.
Sir, peak expiratory flow.
Okay, peak expiratory flow. So let me ask you, what is peak expiratory flow? Just describe it. This
Um,
class is a learning, not just mug up. What do you mean
Just
by
to check
peak
the lung
expiratory
condition.
flow?
Just to
uh,
Right,
check
where
the
you
lung
use
condition.
lung condition. Okay, so
Yeah.
which lung condition you can check by PEF?
So normal functional is it there because already the client is having the shortness of breath in every few weeks. So the as a medical professional, we must understand the lung functions. Okay, whether
Okay.
they're normalized, is it normal or something normal? So we can check with the peak expiratory flow.
So are you happy that patient with the normal or near normal condition, is this peak expiratory flow will going to help or diagnose the things, or how you interpret this? So you have done the peak expiratory flow for this patient. What is your interpretation? What you are expecting in peak expiratory flow?
To
That I
check
want
with the
to.
first, just I just wanted to see that whether the lung condition is normal, then further we can go for that patients.
Okay, so say for example, you did for this patient peak expiratory flow, it is
Yeah,
normal.
yeah.
So do you
Oh,
diagnosed
if
on
it
the
is
peak expiratory?
abnormal, if it is abnormal, then we can think about the different. Okay, I will check with that.
Okay, so if the peak expiratory flow is normal, then would you come to any diagnosis by doing the peak PF normal for this patient? What you supposed to do? Is it diagnosed for anything? Because
No,
patient is
this is
normal
not
now.
diagnosed. This is not diagnosed, but it is a diagnostic procedure. It is not a diagnosis.
Fine. So most diagnostic test, would you think for this patient, PF is the most diagnostic test at this time?
No.
No, 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 no.
Okay, fair enough. Any other comment? Then we'll jump to the diagnosis and answer and all lot of things, right? This is brainstorming, right? We are trying to wake up our own neurons in mock test, right? We knows everything, but we need to interpret, right? While you are reading in the book, it everything is easy, but you need to apply all your brain now of respiratory in one MCQ. So that is more analytic. Yes. Anyone else? Any comment? Any random comment or any comment? Anyone wants? Yes, please. Yes, please. Anyone can comment, no problem. If you shy, you can have a chat box. You can put some words in chat box as well. We have chat box facility as well on the right side. If you see bottom, there is a chat box. So you can answer, you can comment, you can do anything. Fine, fair enough. So if you don't want to comment, I'll switch to the next things, right? So this is what the thing is. Let me check the things, right? So answer is D, more than 20% decrease in FEV1. What do you mean by FEV1? Force expiratory volume in 1 second, like you are blowing the air out of your mouth, like that in 1 second, right? Right? Why this is the answer? Let's go bit in detail. just to get a better clarity, when patient is currently asymptomatic, like our patient is asymptomatic, it is less likely to find increase in FEV1 with short-acting bronchodilator like albuterol, because patient is fine, patient has no bronchoconstrictions at present. So by giving the bronchodilator like albuterol, right, it is less likely that you increase the FEV1. So it's not a good test, especially in asymptomatic patient. Each and every word is important, right? And this test when patient is asymptomatic can be false negative as well. So that is again not helpful. Chest X-ray is not going to help because chest X-ray will show just hyperinflation in asthma patient, nothing else. EBG and peak expiratory flow helpful when patient is acute exacerbation. Acute exacerbation. We are not in acute exacerbation. Our patient is asymptomatic, vital stable, respiratory clear, right? So more than 20% of decrease in FEV1 with use of methacholine is a classical test, especially when patients are asymptomatic and you are thinking that this patient is a asthma. To diagnose that, methacholine is a stress on the bronchus. You give the stress and there is a reduction of the FEV1. So you take at the baseline what is the FEV1, give the methacholine, right? It's a chemical challenge test on the bronchus. Once you give the methacholine and then check the FEV1, if it is more than 20% of decrease in FEV1, force expiratory volume in 1 second, it is the diagnostic of this thing. So you go and open up the chapter master the board. This is the questions I took from there, right? And I have couple of slides from the international journal for you to get little better more idea in every lecture. Specialized test in obstructive lung disease, bronchial challenge test, methacholine challenge test is a bronchial challenge test. Patient is right. What is the indication of this? Patient with suspected airway hyperresponsiveness, right? So this patient is suspected case, right? Why? Because he has intermittent, occasional breathlessness, now normal, but he has intermittent. So it's a good. PFTR performed before and after the administration of increasing dose of methacholine procedure. Interpretation. What is the interpretation? Based on the dose of methacholine that result more than 20% reduction in FEV1 from the baseline, right? So this is what the interpretation. So if you do not have any, I mean, if you give the methacholine and there is no change, it's normal. Even methacholine does not do anything, so he has no asthma, right? Those who have, right? So methacholine challenge test is the most important test, especially in suspected case of asthma when they are asymptomatic, right? So just keep in mind, go and read it once again, the methacholine challenge test, right? So more than 20% of decrease in FEV1 with use of methacholine is the single most diagnostic test at this point of time, right? So that is the answer. So go and read it once again. I wish and I want you to read FEV1, FVC. They asked a lot of question on obstructive and restrictive pulmonary disease, right? So I'm trying to pick up the one important chapter and topic from that. So let's just move to the second question. That is also important. All pulmonary questions you need to, do a lot of brainstorming in each and every questions because there is some logic. So an HIV positive African American man admitted with a history of dyspnea, dry cough, and high LDH and PaO2 of 65 millimeter of Hg. He started on sulfomethoxazole and trimethoprim and prednisone. On the third day of hospital, he developed severe rash and neutropenia. He has anemia and there are bite cells on the peripheral smear. What is the most appropriate next step in the management of this patient? So they are not given here the clear cut diagnosis, right? So what is your first job here to get the diagnosis? You easy diagnosis, you read the scenario. Believe me, every scenario has everything. Only thing is you need to concentrately read it. If you read this file line, you get the diagnosis, you get the investigation, you get the treatment. So they are directly jumping on the management part or treatment part without diagnosis, right? So first of all, your job is to make a diagnosis. If you remember there is three step, you are expert. So we keep some diagnosis in your mind. So what will you do for this patient? You stop trimethoprim and sulfomethoxazole, which was started here, right? begin with the antiretroviral therapy. Why you want to start antiretroviral? Because patient is an HIV positive. Nobody will give you in the clue in the exam, but I'm giving you. Switch TMP SMX to intravenous pentamidine, right? So you feel that something is wrong with sulfamethoxazole trimethoprim. So you stop, you switch from this to intravenous pentamidine, or you switch this to aerosol therapy, or you switch this to clindamycin and primaquine therapy. What is the diagnosis? What is the treatment? Why patient has dry cough? Why patient has a dry cough? Why patient has dyspnea? Why patient has high LDH? Why patient was started on sulfamethoxazole? Why patient has a rash? Why patient has anemia? What is the importance of bite cell on peripheral smear? All are the question in the one slide. Take your own time. I am not in hurry. Those who start, who has to give me the diagnosis. I will not jump randomly. I'll go systematically.
There
Diagnosis.
is a sir bite
Probably
cell.
Yes, sir, I can start,
It
sir.
means I
Actually, he
think
has
G6PD
I can
deficiency,
start
sir.
because he has
one
a
one by one,
PCP.
one by one. Sorry, one by one. If you speak, we can discuss very well. So HIV is there. Already they had given HIV positive patients, right? So HIV
Yes,
is
sir.
there. Along with
Yes.
HIV, what do you think? Patient has a history of dyspnea, dry cough, high LDH. Are you thinking of something else or some condition in
Yes,
HIV
some
patients?
conditions.
The
Which condition?
pneumocystitis.
Some conditions, yes.
Yes, so name of that condition is PCP, pneumocystis carini pneumonia. Pneumocystis carini pneumonia, which classically present. Go and read, open up the book of PCP pneumonia. How they present? Dry cough, yes, absolutely dry cough. Dyspnea, high LDH, right, and hypoxia as well. So this is the classical presentation. So now this patient has a HIV. Now this patient has a suspected pneumocystis carini pneumonia. For your kind knowledge and information, is it bacterial, viral, fungal, or protozoal infection? Another question. In one question, there are many questions. So PCP is organism pneumocystis carini pneumonia. What kind of organism it is? Is it
Fungal,
bacteria,
fungal,
virus, fungi, or protozoa? The fungi.
fungal.
Yes, it is fungi. So many people think that it is a bacterial. It is not a bacterial. It is a fungi. Right? Just two things: the prophylaxis as well as treatment, right? Prophylaxis is sulfamethoxazole and trimethoprim. Treatment same, sulfamethoxazole, trimethoprim. Only dose is different. Dose is different. Prophylaxis different dose, treatment different dose. But the same drug can be utilized. So this patient has HIV. They have likely or suspected PCP, which is a fungal infection presented with the dry cough, high LDH and dyspnea. And because of this is the drug of choice, so they started already on this. But what happens on the third day? He developed severe rash and neutropenia. So what do you think? Why this severe rash and neutropenia develop? Number one.
It's possible
The
G6PD.
side factor of the this drug. These are side
Wonderful.
effects.
Excellent. So, excellent. You are absolutely right. So, sulfamethoxazole zole and trimethoprim is a drug of choice for PCP. Commonest side effect is neutropenia, which they have it, and they have rash. So, they also have rash, right? So, because of this side effect, right? Now this is PCP, right? So, you started the main drug, but so unfortunately, main drug is not tolerating well, or they have side effects. So, what you supposed to do? Are you going to stop this? Are you going to start anti-HIV treatment? Are you going to
You
stop
stop
this
it.
and start this?
Stop. You stop the medication.
No, sir.
We have
Uh,
changed to
So,
No,
intermediate.
so
sir.
those who answered
Switch.
the stop,
See,
let me tell you one by one. Sorry, we'll discuss all. Those who answered stop, that is not a correct answer. By stopping drug, you are not going to cure the PCP pneumonia. So here you need to do two things. You need to stop the drug and you need to start something which covers the PCP. Am I right? Are
But
you
sir,
getting
your
me? Yes or
question
no?
says appropriate next step. Next
yes,
step.
Yeah, in the management of this patient. So you stop the drug, but
Yes, sir.
stop.
But your question says appropriate next step.
Yes, sir,
Appropriate
that's
next
correct.
step
Yes, so appropriate next step is not just
is
to
to
stop the
stop.
drug.
Yes.
You can stop the drug and you
No,
need to
no.
start. Otherwise, how the PCP will going to be cured or treated? You understand? So whenever any
The
side
first
effect
thing
of
to
the
do
drug,
first is to stop the medication first. You stop it first.
yes, you stop the first and then you need to start. So best is not just to stop is not the next best step. Best next step is to stop whatever the drug has a side effect and you start the appropriate next drug of choice for any patient, right? So say for example, patient has antiretroviral therapy, HIV, any side effect, major. So you stop, but you start second line. Like tuberculosis, you started 5 drug of AKT, they had side effects. So you can start second line of AKT. You cannot just stop the drug in any condition, not just this condition, just for your kind knowledge. Anyway, so A is the stop the drug, but better options are all there. So stopping the drug will not solve the problem. So A is gone. Any other comment?
For
Any
patients
other?
having
B
like
is
hemoglobin reaction, we usually
Sorry.
continue to first line is pentamidine. We have to, the first line is pentamidine. If the patient goes to
You can post the
pentamidine,
yeah, you can
follow
post your
the
answer in the chat box. I will ask you by your name. I can see each and everyone. You can post the answer in
See,
chat box,
already the
or
question,
tell one by one.
if you are stopping TMP SMX, then we should switch on to the intravenous pentamidine. That is a C
Wonderful,
option.
wonderful.
We need to be switch
Right,
off. Otherwise, if
wonderful.
you are stopping, then if you are switching on, my answer was A. But when you said if it is stop, then what should be the next option? Then the switch TMP SMX to the intravenous pentamidine.
Wonderful. So this is the tips and tricks to the exam for you guys. Whenever they ask such questions, just to stop. So never ever select just to stop. Look into the other options, stopping that, and is there any drug on which you can switch, right? If there is a no switch option, then this is the most correct answer. Okay, you stop the drug. But when you have the options of stop this and switch to this, then you have to select that for any condition, for any disease, and also in clinical practice as well, right? In clinical practice, if you have given doxycycline, you have rest, so you can't stop. Okay, you go home, everything is stopped. You stop doxycycline, you think of something second line treatment, isn't it? Yes or no? Yes. So why this is not chosen? Options E, why it is not chosen? Because clindamycin and primaquine considered to be the best treatment option or combination for PCP, best combination. Then why you did not use it?
Because
similar
because
to
primaquine is the
increase the hemolysis, sir.
Wonderful, wonderful, wonderful. That is the option. So primaquine is especially in G6PD deficiency, it increases the hemolysis. So what is the problem here? Patient has already anemia. Patient has a bite cell. So bite cells are suggestive of G6PD deficiency, bite cells. So in that condition, if the bite cells are not there, if anemia is not there, the answer is E. Believe me, answer is E, right? But if the bite cells are there, anemia is there, already hemolysis is there, already G6PD deficiency is there, by adding pyrimethamine, right, or any sulfur drug, which can increase the hemolysis, right, and makes the condition more worse or maybe more severe anemia. So that is why it is not the option. Otherwise, this is the best option. This is not the option. Why begin antiretroviral therapy? Why you are not going to start antiretroviral therapy? Because patient is has HIV. But right now patient has a PCP, he is not suffering from HIV. So once PCV gets controlled, you can start with the HAART, highly active antiretroviral therapy or anti-HIV therapy. Starting at this point of time will cause a constitutional or serum sickness, right? So it is not the right time to start at the time of infection. Once they gets resolved, right, you need to start eventually, because primary condition is HIV. So you need to start, you need to supposed to start. But by starting HIV at this point of time will not going to cure the PCP. So this is not a good treatment option at this point of time, right? Aerosol therapy is less effective than intravenous pentamidine, and that is why sulfamethoxazole, you stop it and then start the pentamidine. That is the best next appropriate options for this patient. Let's jump to the literature quickly. I already told you. So switch TMP SMX to intravenous pentamidine. Rash is most common, and neutropenia and bone marrow suppression is the second most side effect of sulfamethoxazole trimethoprim, which our patients already have. Our patient has neutropenia, anemia, rash. Although clindamycin and primaquine may have more efficacy than pentamidine, but why we did not use it? Because patient looks G6PD deficient and primaquine is contraindicated. Bite cells are suggestive of G6PD deficiency. So for that reason, right, the best appropriate option is pentamidine is used, not the aerosol, right? And starting antiretroviral therapy done eventually. When you, in addition, antiretroviral therapy is relatively contraindicated while acute opportunistic infection, because there must be a immune reconstitutional syndromes could be there. So this is the explanation for all the options in this scenario given. So before I close my this questions, if anybody has any questions or comment, it's highly appreciated. Hopefully I'm clear, pretty much clear from my side. Yes.
Sir, pentamidine is the antifungal drug or antiprotozoal, sir. Little will
eh,
confuse, sir.
Yeah. So
Antifungal.
pentamidine, yes. So pentamidine is a best appropriate options, right? So pentamidine drug could be used. Pentamidine is a medication used for the especially the PCP pneumonia. Just write two more indication. One is leishmaniasis. If they ask you in the exam, and third is a trypanosomiasis. It's a antifungal drug. Just for your kind knowledge, it's an antifungal drug, right? Because PCP is a fungal, so pentamidine is a fungal, right? So this pentamidine three indication once again: PCP pneumonia, pneumocystis carini pneumonia, leishmaniasis, trypanosomiasis, and it is antifungal drug. Is that clear?
Okay, sir. Yes, I have a question with
Okay, okay,
regards
sir.
to the first question, sir. The first
Sorry,
question,
sir.
the previous question.
Yes, so I'll jump to the next questions for you guys, right? So I
Sir, the
already
previous
explained.
question, I have a question on that.
Yes, tell me any questions?
Yes, my question is regards to the previous question.
Yes, please.
So in that question, you said the answer is the metacolin challenge test. So ideally, I want to know in clinic practice these days, how often do we do the challenge test, the MCT test?
We are doing it, sir. In our center, we are doing it. Methacolin challenge test is we are doing it. It is not something
Okay,
unusual or very rare test.
okay.
Yeah. So let's jump to the next questions. Probably this is easy but important. So there are a lot of literature I had given you. So I'll share this PowerPoint on our YouTube channel by end of the evening, so you can revise it once again. Right? Young patient, young patient, no comorbidity, otherwise fine, with history of cough, chest pain, fever, chest X-ray shows right lower lobe infiltrates. Right, you can see it here, right middle lower or right lower lobe infiltrate. This is normal. How you supposed to read the X-ray? This is normal given here, and here somewhere lower zone, right lower lobe infiltrates. Right. What is the diagnosis? What is the treatment? Simple question. Amoxicillin, cefuroxime, imipenem, ciprofloxacin. What you supposed to use in this patient and why? What organism you are thinking? Lot of questions in these questions. First question is, what is pneumonia? Definition of pneumonia. I want to know. Second thing, how you classify the pneumonia? How you classify the pneumonia? What, right? What are the types of pneumonia? Right, lots of questions on pneumonia, and it is leading cause of death globally. Millions of people are dying, so you must know each and everything about pneumonia. Yes, go ahead. Another question is, what is typical versus atypical pneumonia? We know from many days, oh, this is typical, this is atypical. So today we will clarify 100% thing is next 5 minutes about all pneumonias. Yes, but I want to know from your side what you supposed to give to this patient and why.
Okay,
So
so
it's a simple
we can
question.
give the patient amoxicillin.
Yes, sir. Yes, tell me, sir. Sorry.
Amoxicillin.
Amoxicillin. Okay, fine. Fair enough. Fair enough. Your answer is fair enough. Right. So amoxicillin, why? Now, next question. Why not cefuroxime? Why not imipenem? Why not ciprofloxacin? What's your explanation? Because our
This
job
is
is
a
to
simple case of
understand.
community-acquired pneumonia. For
Sorry.
first-line treatment is amoxicillin. This is a simple case of community-acquired pneumonia. From the history, there is cough, chest pain, and the fever, chest
Sir,
X-ray
it
showed
caused by,
right
sir,
lower.
Streptococcus pneumoniae.
Okay, so Streptococcus pneumoniae, right? Fair enough. Streptococcus pneumoniae. Is it typical or atypical?
Is typical.
It's typical.
Typical or atypical?
Typical.
Typical.
Okay, fine. So
Typical.
can anyone define me what is typical and what is atypical?
Typical, it means there's cough and fast breathing. Extrapulmonary manifestations are not common, and
Caused by
patient history
Streptococcus
and
pneumoniae, sir.
X-ray is comparable.
Fine, fair enough. So I would classify completely clear-cut picture about uh, typical versus atypical. So you never ever had any confusion in the future. Let me have my slides, please. So I have excellent slides for you to make you understand, right? Typical versus atypical. I'll, fine. Slides are coming down. So this is just the quick, right? I have seen there are lots of doctors, those who have not complete clear cut clarity about the pneumonia. What is exactly pneumonia? How you define pneumonia? So this is most simplest definition I come across for you. I brought it for you. So what is pneumonia? Pneumonia is often an infection in your lungs caused by usually bacteria, virus, fungi, or parasite as well. Pneumonia causes your lung tissue to swell, that is called inflammation, and can cause fluid or pus in your lungs. Bacterial pneumonia is usually more severe than viral pneumonia, which is often resolved by its own. So, pneumonia is basically an infection of the lung caused by either bacteria, virus, or fungi. And because of this infection, there is a swelling or inflammation in the respiratory tract. And because of that, there is a makeup. This is normal alveoli. This is normal healthy alveoli. And you can see fluid and eventually a pus will fill. And then eventually you develop the pleural effusion. Eventually you develop the empyema. Eventually you develop the septicemia. Eventually you develop respiratory failure. And eventually you develop the death. This is the cascade, and that is why we need to treat this pneumonia, because these all are the complication. I told you pulmonary effusion could be a complication because continuous fluid secretion in the pleural sac, right? Eventually infection develop in that fluid, empyema, pus in the pleural cavity, right? After that, that may shade to the systemic circulation, then septicemia, acidosis, hypoxia, respiratory failure, and death. So don't neglect the pneumonia in any patients, whether it is a pediatric patients, middle age, young age, older age, more common and severe in pediatric and older age, and immunocompromised. We'll see sometime, but this is the most simplest definition by my sense of pneumonia. Here it is showing, right, what happens in pneumonia. Here the normal alveoli, here fluid filled, right, and then eventually pus may develop. Causes, it could be a bacterial pneumonia, it could be a viral pneumonia, it could be a fungi, it could be aspirational pneumonia. More common, as gentleman rightly told, streptococcus pneumoniae is the most. Streptococcus pneumoniae is the most common, right? So streptococcus pneumoniae, and which is covered by the penicillin or amoxicillin. That is why it is a first drug of choice, amoxicillin or penicillin. So streptococcus pneumoniae is the most common cause of bacterial pneumonia in adult. Our scenario is young adult male, young adult male. So our young adult, right? So adult streptococcus is more common. Drug of choice is amoxicillin. Apart from that, other bacteria, mycoplasma pneumoniae also can cause. Viruses, we recently see flu and influenza, we know cold and flu, we years and years, we recently had a COVID pandemic, right? SARS virus, COVID pandemic. So it was viral, right? COVID virus, COVID-19. We have seen, everybody of us have seen the disaster of COVID. It's a viral pneumonia, or it is atypical. It falls under atypical. Fungi is a fungal pneumonia, is less common and particularly affect with a weakened immune system, especially leukemia patient, chemotherapy, chronic diabetic patients, organ transplantations. Those who have at the high risk of developing fungi or fungal like candidiasis or aspergillus pneumonia. So this is more commonly seen in immunocompromised. Aspiration pneumonia, so anything gets into the, while you are drinking or eating or vomitus or swallowing it, instead of going to the esophagus, it goes to the lung. That is called aspiration pneumonia. You aspirate the material. in the lung, right? So that is what the common type of pneumonia which you must know. There are lots of interesting things for pneumonia. You will love it. So we should know it what the pneumonia is, right? So this is the basic things. Another important slide is also important. What is the difference between viral and bacterial pneumonia? While all pneumonias cause inflammation caused by an infection in your lung, you may have different symptoms depending on what means which lobe involved, how much is the infection, underlying immunity, age of the patients, blah blah. But this is in general. So bacterial pneumonia tends to be more common and more severe than the viral pneumonia. It is more likely to require a hospital stay. Providers treat bacterial pneumonia with antibiotic. Viral pneumonia can like a flu-like a symptoms and more likely to resolve by its own. You usually don't need specific treatment of for viral pneumonia. So we have seen this is in the COVID as well. So there are millions of people those who are quarantined, right? They are quarantined at home, right? They did not went to hospital. Only severe patient went to hospital because majority of the patients are at home. They had supportive care, isolation, good fluid. There is no antiretroviral or no anti-COVID treatment was given to any patient globally. Just supportive care, right? So that is what the thing is. And I already told you the complications, right? So complication is one by one the cascade, which is important. That is why I'm going bit in detail, but it's important. Breathing difficulties, right? So respiratory failure. So respiratory failure, there are type of type 1 and type 2 respiratory failure. So if you don't know, this is your homework. Go and read it. Respiratory failure, what is type 1, what is type 2, what causes type 1, what causes type 2, what's the treatment of type 1 and type 2. That's it. Fluid, right? So pleural effusion can be there. Eventually, sepsis is there, lung abscess or empyema there, acute respiratory failure, and death could be there. So these are the major common side effects of pneumonia. So any pneumonia, you're not supposed to take it lightly. Now, this is specific questions several times in the exam, right? So the table summarize the specific association of pneumonia causing organism, specific association. So say for example, patient has a recent viral infection, right? Staphylococcus is the most common culprit. Patient is alcoholic and develop pneumonia. Klebsiella is the commonest organism. Patient has a gastrointestinal symptoms, confusion, and develop pneumonia. Legionella is the commonest infection. Young healthy patients, Mycoplasma pneumoniae or Streptococcus pneumoniae is the common. As we seen, person presents at the birth of an animal, right? Person present at birth of an animal. Coxella, right? Arizona construction worker, coccidomycosis, HIV with less than 200. We have recently seen PCP, cough, fever, dyspnea, high LDH, PaO2 low, PCP classical. So you need to little mug up. See, I don't have any clue and tricks and tips for this. So this is given in the book as well, Master the Board. So they many a times ask, alcoholic patients develop pneumonia, considered of Klebsiella. HIV positive patient develop the pneumonia, think of PCP pneumonia. Young healthy patients develop, think of mycoplasma. Likewise, right? So this is what very interesting and important things. They ask many a times this question. So this one chart will help you, but you need to little mug up this, right? So pneumonia top 6 manifestations, right? Fever is the most important, productive cough, crackles because of this, dyspnea, chest pain, and in advanced stage, you may have the altered mental status. This is the most important things. I already explained you this part as well. So not going much in detail once again, right? This is the same thing, right? So lobar pneumonia, another classification. One classification we see bacteria, fungi, virus, protozoa, and aspiration. One another is site of the lobe, right? So this is the lung, right? So upper lobe, middle lobe. So one lobe is involved lobar pneumonia, right? Lobar pneumonia, or they may have two different lobe involved, right? So infection in one or more lobes. One lobe, upper lobe, middle lobe, lower lobe, lobar pneumonia. What are the causes? Lobar pneumonia common like this patient, young adult healthy, streptococcus pneumoniae, right? And symptoms are almost same. Only things you need to remember is rusty colored sputum. Bronchopneumonia 2. Broncho means bilateral. Simple way. Bilateral. Broncho bilateral. Or another way is double pneumonia. Sometimes in our community they say double pneumonia. Double pneumonia is bronchopneumonia because it is broncho, B for bilateral, B for bilateral. So broncho means bilateral, both lungs. Both lungs is bilateral. B for bilateral. Broncho means B for broncho. So BB, remember BB, broncho bilateral, right? So usually they are bronchopneumonia, B bronchopneumonia, B both the lungs, right? There are several organisms here. Little change is a yellow or green sputum. Here rusty sputum. This is specific point you need to remember, which will help you to crack some MCQ in your exam, right? So this is classical presentation, and this is what the basic important thing is. What is the important? First is chest X-ray. You see the elevated counts. You see the consolidation in the upper middle lower lobe. You see elevated white blood cell count because it's an infection. So WBC gets elevated. Sputum culture is the best, which gives you the idea about the diagnosis and advanced case, whether patient is in respiratory distress. You go for the ABG, look at the acidosis. If it is there, you need to treat it. So this is all advanced. I told you already the key sign symptoms. So here the answer is amoxicillin. Lobar pneumonia is often due to Streptococcus pneumoniae. Amoxicillin is the drug of choice, right? So we discuss everything. So you need to keep in mind how you do it, how you differentiate it, right? So here again, once for a young outpatient with non-severe pneumonia, amoxicillin is the first line treatment or choice of the drug is effectiveness against the common bacteria and safety profile is well proven for many years, especially given at the higher dose, they are fine. Severe cases or those suspected to be caused by atypical bacteria like mycoplasma, chlamydia, right? In that case, you use the azithromycin or macrolide is azithromycin can be used and cephalexin can be used. So this is the basic information you must know for all pneumonia. So I tried my level best to whatever the maximum questions they ask for the pneumonia, I try to cover it. So just go in detail. We need to cover one curve 65. That would be a different separate questions in next couple of slides. So we'll do it. Next question in front of your screen. Patient with PPD, past protein derivatives or Montuk's test is positive or MT is positive or tuberculin test is positive. Chest X-ray negative patient has no other symptoms. What to give him, right? What's the diagnosis in this patient? You need to make first diagnosis as per my triad. INH for 9 months, INH reform SIN for 9 months, reassurance, no need any treatment. Why? Because patient X-ray is normal and symptoms are not there. So just surveillance. 2 months of 4 drug AKT should be given to the patient or any other options in your mind.
Okay, so I'll go with option B. Sorry, option A.
Okay, fine. So you go with option A. Fine. What is the diagnosis, sir?
Latent
Okay,
TB.
okay. Actually, it has a latent TB.
Yes, fine, fair enough. This could be a latent TB. So now can anyone tell me what is the head-to-head comparison or what is the exact difference between latent TB and active tuberculosis? Fine, fair enough. I'll tell
In
you on
latent
behalf
TB,
of you just to save the time. So latent TB, active TB. So latent TB usually symptoms are none, right? Patient has no symptoms usually. Like our patient is only PPD is positive, right? Our patient has chest X-ray
Going now.
negative,
Take
means
care.
normal. Symptoms are
Okay.
negative or there is a no
They're
symptoms.
not
So only
paying me.
just PPD is positive. So symptoms are nil. So this is usually
Everybody
active
receive.
tuberculosis have a
Everybody.
symptoms.
You have.
Please don't talk in between. I mean, it distract my mind. Whatever you want to ask me, you ask me. I'll mute all.
Yeah.
Yeah. So the active tuberculosis have the symptoms, usually the symptoms of TB basically, right? So we know fever, night sweat, weight loss, evening rise fever, cough, sometimes hemoptysis, blah blah. This is symptoms in active TB, not in the latent TB. So latent TB does not have symptoms. Active TB does have. Yes. Infectivity, right? Are they infective? No, it is non-infectious. This is infectious because active TB they can spread from one person to another, while latent TB does not. Right? Tuberculin test is positive. Yes, it is positive in both the way. But we decide once when the tuberculin is test positive or PPD is positive to any patient, how we supposed to know whether it is the latent TB or active TB? These are the differentiating point. Latent TB does not have symptoms. Latent TB have chest X-ray normal. Active TB has a symptoms, active TB has a positive chest X-ray, they may have positive sputum culture. So tuberculin test positive in both the things. Sputum AFB is negative, obviously, because it is negative, and here usually positive, but it could be negative, but it is usually positive. Chest X-ray is usually normal here, and you can see here the abnormal chest X-ray. And treatment, consider treatment to prevent progression of the active. So if you don't treat latent TB, it will eventually progress to the this thing, right? So literature. So what is the literature? 10% of the patient annually, right, of latent TB, if you don't treat, they will go to active TB, 10%, right? And what if you treat this latent, right? Because you don't want any patient to go from latent tuberculosis to acute tuberculosis. So you need to do something. You need to give some drug. So drug is INH, isoniazid, for 9 months as per the guideline. You need to give this to this patient who has latent TB, and which reduces 10% to risk up to less than 1%. And that is why you need to treat the latent TB. And this is head-to-head complete classification and clarification for you guys to understand, right? So hopefully you understood, right? Am I right or wrong?
Sir,
Are you getting me? At least tell me yes or no. Are you getting me?
yes,
Yes,
sir.
sir.
Yes, sir. Yes, sir.
Yes,
Yes,
Sir,
sir.
sir.
one
Yes, sir.
question.
Yes, sir.
Wonderful, wonderful. So we'll go ahead.
Sir, one question.
One, yes, please.
Sir, this is updated 9 month because now ND2 treatment is for 6 months.
As per the options, sir, still it is in the book. I got it everything from the book. I am not taking anything out of the book, all standard book. So still the answer is INH for 9 months. Isoniazid alone is used for 9 months to treat positive PPD. This reduces the 10% lifetime risk of developing tuberculosis to 1%. That is what I already explained you. And it is taken from the reference is from Master the Board Step 3, right? So you just go and cross check it. There are few other options, but as per our option, what is the best? So INH is best. You don't need to give both the drug, right? Even it is not given 9 months for even active TB, right? 2 months 4 drug and 4 months 2 drug, right? This is what give. Reassurance is not a good options because PPD is positive. You need to do. You don't want this latent TB to go into active, so this is not. And this is the treatment is not treatment for the INH. You don't need to be that much of aggressive for latent TB to add 4 drug AKT for 2 months doesn't required. Is that clear?
Okay, sir.
Right? And before that, another, so this is latent versus this tuberculosis. And another excellent important, you must, each and everybody must know the side effect. INH, there are 5 drugs: INH, rifampicin, pyrazinamide, ethambutol, and streptomycin. This is called as the first line treatment for the tuberculosis globally. So INH, N means neuropathy, N means neuropathy. So neuritis, peripheral neuritis. It is peripheral neuritis. So you must give pyridoxine, vitamin B6. The name is pyridoxine. So pyridoxine must give to each and every patient of the patient who are on INH, because there are 3 side effects: neuritis, hepatitis. So every 2 to 4 weeks you need to do a liver function test. It may eventually develop the hepatitis, and when you have a bad hepatitis, you need to stop the isoniazid as well. So hepatitis, and you need to switch, not just stop, you need to switch to the second line. So INH, peripheral neuritis, hepatitis, and SLE like symptoms, SLE. So these 3 specific side effects you must remember. They are asking many times. Rifampicin means R, R means red urine. So red urine is a orange color urine, and secretion, even the patient who are on AKT, they have red tear, not a white colorless tear, right? So rifampicin means R, R means red urine and secretions. Pyrazinamide, uric acid, uric acid is high. So those patients who are having a gout already and develop the tuberculosis, and you are starting the pyrazinamide, monitor closely or add allopurinol. Allopurinol is a drug of choice. Another second drug is a febuxostat. And third drug is ras buricase. Go and read it bit more in detail of pharmacs. So these are the drug of choice to prevent hyperuricemia or gout, especially in this patient. So INH3, rifampicin, R for red, pyrazinamide means uric acid, E, ethambutol means E means I means optic neuritis, right? So optic neuritis is the side effect. Streptomycin, omycin means ototoxicity or deafness. So this is the specific side effects of all AKT. They are several times asked in various exam of DHA, the MOH and all, plab and all. Is that clear to everyone? Yes or no?
Yes, sir.
Wonderful.
Yes, sir.
This is
Yes, sir.
the wonderful. This is the answer. Let's cover few questions more. Hopefully, you're not getting bored with me now. I'm on the peak of my lecture, so I'm enjoying a lot. 44-year-old woman, non-smoker, had a fever and cough for past 4 days. She does not have hemoptysis. She has no experience weight loss, malaise, nausea, or vomiting. On examination, temperature is 37.6. There are decreased breath sounds on the right upper lung or lobe. A chest X-ray reveals 6 centimeter area of infiltrates in the right upper lobe. She is given a course of antibiotic therapy, but her cough persists, does not resolve. A month later, chest X-ray now reveals 3 centimeter peripheral mass in the right upper lobe. Which of the following neoplasm is most likely to be present in this woman? Squamous cell carcinoma, small cell anaplastic carcinoma, adenocarcinoma, mesothelioma, carcinoid tumor, or something else? Take your own time. Don't forget my triad. If you do not forget my triad, you will be expert. They had not given the diagnosis. They're asking
Adenocarcinoma.
you directly. So, what is a suspected case? What could be?
Sir,
Yes.
adenocarcinoma.
Okay. So that means before jumping to that, I'll just jump. Is it lung cancer, right? You are likely dealing with a lung cancer, isn't it? Yes or no?
Yes, sir.
Right.
Yes,
What
sir.
makes you to think of lung cancer in this patient? Patient is a woman. Patient is
Mm.
a non-smoker. So how you supposed to think of the lung cancer in this patient?
Is unresponsive to
Can you
antibiotics.
make your mic bit closer? I have blood voice. Yes, please. Go
Uh,
ahead.
she, she was given antibiotic therapy, but she was unresponsive.
Okay.
3 centimeter mass in the upper lobe.
Okay, great. So there is one clue. There is a mass in the upper lobe. So mass,
Weight
obviously,
loss,
think
sir.
of
Hemoptysis.
Yeah, hemoptysis.
No,
hemoptysis. Where is
it
the
does not have
hemoptysis?
hemoptysis. No hemoptysis.
No,
Um,
does not have, does not have, does not have. So no
They have given
hemoptysis.
sir antibiotic, but there is
Cough is
lots of cough
persisting.
Super,
in the
excellent. So
cancer.
given the antibiotic, see, it's important.
Yes.
So if it is a pneumonia, if it is something infection, by antibiotic, it's supposed to resolve. She is given a course of antibiotic, but her cough persists, does not resolve. And what happens? Earlier
But
there was mass, right? So a chest radiograph reveals 6 centimeter area of infiltrate in the right upper lobe, right? Infiltrate in right upper lobe, and now there is a on right after a month, right? Her chest X-ray reveals 3 centimeter peripheral mass. That was something infiltrate. Now it's mass in right upper lobe, right? So this is likely a lung cancer, right? Just for your knowledge, 90% are tobacco user, but 10% are no tobacco user, no smoking, female. It is seen in 10% of. So she is in 10%. Female, non-smoker. So it's not always mandatory. That is take home message. Take home message is right. Always not develop in this smoker only, non-smoker as well. So now let me tell you the difference. We don't need to mug up. So this is a picture. Let me explain you. So there are two classification mainly for lung cancer. So when there is a is lung cancer, when we are talking about primarily two things, right? Non-small cell and small cell. Small cell lung cancer is just 10-15%. Non-small cell is around 85%. Rest is 18 plus 15 is 100%. Right? So 80% are non-small cells, shortly known as the NSCLC, non-small cell lung cancer. SCLC, small cell lung cancer. This is how it is, what we do it for last 20 years in our clinical practice. This is how internationally classified. So first you need to know what is this, whether non-small cell or small cell. Small cell, only one pathology, small cell carcinoma, that's it. But in non-small cell, there are three category. One is adenocarcinoma, another is squamous cell carcinoma, third is large, and fourth one is there undifferentiated kind of things. But we're not going in detail of lung cancer at this point of time. But this is basic. You must know. Amongst this 87, 85%, adenocarcinoma is the most commonest, 40%. Squamous cell is 20 to 30%, second most common. Large is the third one, 10-15%. So this all cumulatively becomes 85. This is only one category, right? So this is first thing. So anybody talking to you about lung cancer, first decide whether it is a non-small cell or small cell. Number one. If it is non-small cell, it is adenosquamous or large cell. Second thing. Now come to the location. It's very important. This is all comes from the experience. I treated many 100,000 patients for lung cancer. So this is trachea. This is a right bronchus, left bronchus, and then this is all bronchi and all blah blah. So central, this is central and this is periphery. Peripheral is peripheral part. This is a central part, right? Trachea is in center, no? So in center, I tell center as a S, center. So this S will continue. Center, small cell. Center, squamous cell. Is that clear? Yes or no? At least tell me yes or no.
Yes, sir.
Yes, sir.
Wonderful. I'm trying to give you the most easiest ways how you supposed to remember. Otherwise, it took so many years for me to understand this. Being a medical oncologist, I'm accumulating my all 20 years of experience in this lecture. So be concentrated. Center. So center S. Start from C, but S for center. So center arising squamous and peripheral is adenocarcinoma. Peripheral is adenocarcinoma. So they are saying 3 centimeter mass develop in peripherally. So likely adenocarcinoma. It is developed usually in a non-smoker. Squamous cell usually develop in a smoker. Adenocarcinoma usually develop in a non-smoker. Our patient is a non-smoker. Adenocarcinoma develops peripherally. Our patient has a tumor, peripheral tumor. Is that clear? Yes or no? At least tell me yes or no.
Yes,
Are
sir.
you
Yes,
getting
sir.
me? Yes or no?
Yes, sir.
Yes, sir.
Yes, sir.
Wonderful, wonderful, wonderful. So this is what the basic things about the lung cancer. And again, I already told you the classification. This is the lung. 15% are small cell, 85% are non-small. Squamous, adeno, and large are in category of non-small cell lung cancer. Why it is non? Because they are not look like a small cell, like a Hodgkin's and non-Hodgkin's. Hodgkin's lymphoma one category, non-Hodgkin's lymphoma subcategory. We treat every day in our practice. There are several 50 subtype of non-Hodgkin's lymphoma, 5050, follicular lymphoma, diffuse large B cell lymphoma, mantle cell lymphoma, Burkitt's lymphoma, right? Peripheral T cell lymphoma, lymphoblastic lymphoma. So it's all non-Hodgkin's lymphoma. Hodgkin's one category where you see the Reed Sternberg cell, all eye. So you will enjoy hematology with me sometime down the line because my primary job is hematology. So you will love it. Anyway, so this is what the thing is. So I think it is clear cut pretty much picture. I don't think so it is confusing picture, isn't it? Yes or no? Right?
Yes.
So this is now you go back to the things. So what they are saying, 3 centimeter peripheral mass. So squamous cell is not peripheral mass. Central, S means central. S means central. So central is squamous cell, central is small cell. Peripheral is adenocarcinoma. Is that clear? Yes or no?
Yes, sir.
Wonderful. So this is what
Yes,
all
sir.
things is all about the lung cancer. So you go and read it, right? So there are a lot of whole day lecture for lung cancer, but not going much in detail. But just you need to know the things, and your homework would be, right? Is there any screening test for lung cancer? First answer, yes or no. Lung cancer, is there any screening test like breast we do mammogram, for cervix we do pap smear, for prostate we do PSA, for
Yes,
colon we do
sir.
colonoscopy. So like that,
Yes, sir.
Yes.
Yes, sir. Yes, sir.
any test for
Yes.
lung
Do a
cancer
low dose
screening,
chest CT.
low dose CT scan. Yes,
Yes,
absolutely
sir.
correct answer. Perfect answer. Low dose CT scan. Who qualifies? Are you going to advise to each and every patient in community low dose CT scan, or there is a sub
No,
or
no,
specific
sir.
No,
No,
doctor,
sir.
category where
smokers only.
high
Smokers.
risk, high risk, high risk, high risk patients? So what are the high risk patients? That is again a question. So those patients who have
Smokers.
more than 55 years, 30 pack per year they are taking, right? They are considered as a high risk, and high risk will develop high chance of lung cancer. So not low risk, you should not supposed to advise low risk. Those who are especially non-smoker, they are the low risk. High smoker, chain smoker, 30 pack per year, right? Low, where you supposed to do the low dose CT scan annually, not every 3 months, annually. Is that clear to everyone? Yes or no?
Yes.
Yes, sir.
Wonderful. So go a little bit in detail as well. So let's jump to your little CUP 65 knowledge, right? CUP 65 knowledge should be applicable to all patients of pneumonia. Pneumonia, we have seen pneumonia very well. Pneumonia, right? So it's an inflammation in the respiratory tract, especially the alveolar or air sac, where eventually fluid and pus accumulation, right? And they develop fever, cough, pruritic chest pain, dyspnea, eventually septicemia, respiratory failure, and they may die. Either it could be a bacterial, viral, fungal, or aspiration pneumonia, or it could be pneumonia of lobar pneumonia and broncho. Broncho means both, both means broncho, broncho means both. Bilateral pneumonia, lobar is only single side, streptococcus pneumonia is common, drug of choice is amoxicillin, blah blah. This is kind of revision, right? So this is COP 65. So 67-year-old woman is admitted to accident and emergency with pyrexia means fever and a cough productive green color sputum. The observation shows the pulse rate of 101, blood pressure is 80 over 60, respiratory rate is 32. She is alert and oriented in space and time, and result reveals WBC of 21,000. Her urea is 88.5. Chest X-ray shows consolidation in lower zone of right lung. She is treated for severe community acquired pneumonia. Which of the following is the correct calculated CURB 65 score? So first of all, someone has to tell me what is CURB 65. Number one, basic question.
C for confusion.
Sir,
Admission
C for
criteria for
confusion.
I write
pneumonia,
down on behalf of you.
C for
I
confusion.
write down on behalf of you. Confusion. U means
Urea.
uremia.
U for blood urea, more than 7.
R means respiratory
Respiratory
rate.
rate,
B means
30.
blood pressure.
42.
And
Blood
65 is
pressure,
the age.
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 So just for your knowledge, if confusion is there, 1 point. If confusion is no there, 0 point. If uremia is there, 1 point. If uremia is not there, 0 point. If respiratory rate is more than 30, less than 30, 0 point, more than 30, 1 point. If blood pressure is less than 90, it is 1 point. It is normal blood pressure, 0. If age is more than 65, 1 point. And if it is age less than 65, 0 point. So I told you complete clear cut picture. Now you calculate. You calculate in your note or in your mobile or whatever. You read the scenario. You need to say five things in the scenario and give the score. Whether score is 2, 4, 6, 8, 9, 10, what is the score?
There is a 4, sir, for his answer. One,
You
one is
post in the
age.
chat box because we are 50 doctors now in the class, so it's difficult for me to understand. So you post in the group, in the chat box, what is the score? 2, 4, 6, 8. Yes, please. Yes, anybody wants to try? So now this is the criteria. Confusion 1, urea more than 7 millimole per liter 1, R respiratory rate more than 31,
मैं
B
एक
blood pressure
ट्राई
less than 90,
करूँ
65,
मैंने
right? So this is a
पर
score,
मतलब ये
right?
मामू के साथ खाना अच्छा नहीं लगता डेली खा लेता है ना
Right. Yeah. So we'll see the score. We'll see the score. So first of all, confusion is there. Anybody can tell me confusion is there or not? C means CORB 65.
No
Conf
confusion. She's
No,
alert.
No
sir.
confusion.
no
No,
no
sir.
confusion. No, 1 minute. Let me my C confusion. no confusion means 0 point. Why? Where is it is written? Patient is oriented, not confused. Patient is alert. So confusion is not there. So score is 0. U means uremia, more than 7. What is here? What is the condition here? 8.5.
Yeah,
Right? So anything more than 7 is 1 score. So uremia is 1 score. CUR, respiratory rate more than 31 point. Patient has a respiratory rate 32, more than 31 point. Right? Blood pressure less than 91 point. Patient has a blood pressure of 80 by 16, 1 point. And age, CURB 65. If it is more than 65 age, patient has 67 age, so 1 point. So calculation 0 plus 1 plus 1 plus 1 plus 1. If I'm not wrong, it's 4. Yes or no?
Yes, sir.
yes, sir.
Yes,
Yes
sir.
or no? Wonderful.
Yes.
So this is a score 4. This is how you have to calculate in exam. Don't get confused. You don't need to be in hurry, right? You need to understand the proper things, right? So this is called 65. Our patient has a score 4, right? So score 4 is high. So our patient just remember score 4, right? 0 to 1 curve 65, 0 to 1 risk category 1, or you can say low risk. Better word is low risk, right? And mortality at 30 days is a 1.5%. So out of 100 patient of pneumonia with score of 1, one patient will die, 99% will survive with the treatment, right? If your score is 2, why you want to know the score? Why the curve 65 comes in the picture? Confusion. Why this curve 65 comes in the picture? You are categorizing this patient to low risk, intermediate risk, and high risk patients, right? And depends on this risk category, how you supposed to treat them: outpatient, inpatient, ICU, blah blah. So 0 or 1 is low risk. You can considered home treatment. You give some azithromycin, amoxicillin, oral, go home. Come after follow for 1 week. Right? You don't need to require hospitalization. Low risk. 2 is 9%. See the close to 10% mortality. Year 1, 10 is added. So out of 100, 10 will die if you don't treat them well at the end of 30 days, mean 1 month mortality. Probably admission, they need it. And 3 to 5, our patient has a 4, category 3 or high risk, you can say 22%, close to 25%. So out of 4 patient, 1 patient will die if they are in high risk, or out of 100, 25% patient will die, means 25%, close to 25%. They must need the admission, manage as a severe pneumonia. You need to treat them well by blood culture, by chest x-ray or CT scan or sputum culture. Try to find out the organism and treat accordingly, otherwise they will die, right? So this is the importance of CORP score. You don't need to just, oh, CORP score, but what is the importance, clinical significance and importance of CORP score to get the idea about the severity of pneumonia, and depends on the severity how you supposed to treat outpatient, inpatient, ICU, mortality, blah blah, and counseling of the patients and their relative is also important. So now onwards, any patient comes to you for pneumonia, always calculate the CORP score. Is that clear to everyone? Yes or no?
Yes, yes,
Yes.
sir. Yes,
Yes,
sir.
sir.
Wonderful.
Yes, sir.
Wonderful. Wonderful. So this is what
Yes.
the all stories I already been told you, right, about the COP 65. So this is all written here, but I had given you the crux of the things. Yes.
So in
So
that explanation,
yes.
so in the question number 6, that explanation they said, and should not be used as standalone tool for assessing the severity of pneumonia. Can you please explain that, sir?
COP 65,
Uh,
65 criteria is regarded as a prognostic score and should not be used as a standalone. Means this is not the only criteria. General condition of patient is not there. Immunocompromise is there or not there. Patient has some kind of diabetes, blah blah, something there not. So you need to see the patients as a whole. This is not the only sole criteria to admit the patient, but it is one of them which gives you the overall idea about the prognostication of the patient, right? So this score is very important, right? So if you don't know, say example, patient comes into the emergency room, he is altered conscious, he cannot able to give the history. In that case, what you supposed to do? You just use the CUP 65. Okay, fine. This is one, two, three category, low, intermediate, high risk. Depends on that you treat the patient. But this is not the only criteria to admit. You understand?
Yes, sir. Thank you very much.
Wonderful. Which of the following organism, just bear with me more 10, 15 minutes. It would be very interesting going. I'm absolutely addicted to this now. So, which of the following organism would typically be found in the patients with atypical community acquired pneumonia? Staphylococcus pneumococcus species, Streptococcus pneumoniae, Legionella pneumophilia, Haemophilus influenzae. My question is also there. This is case of pneumonia. They're asking you atypical community acquired pneumonia, right? So, how you differentiate typical versus atypical? I missed that earlier, so I'll cover now. So first answer this. This is diagnosis here is pneumonia. They have given community acquired pneumonia. So it's pneumonia, right? Investigation or organism you supposed to tell me and treatment later on you have to tell me, right? So what do you think? Atypical community acquired pneumonia. Anyone wants to comment? Yes. Anyone wants to comment? Fine. So let me give you the clarity about the typical versus atypical. We are reading for many years and we did a lot of patient seeing, but we are confused what is typical, what is atypical, right? So likewise, I'll tell you head-to-head comparison, typical and atypical. So typical is sudden onset, atypical is gradual onset. Sudden means within hours to days. Gradual means in a days to weeks. This is gradual. Typical usually they present with the productive cough with sputum. Here usually non-productive cough. The biggest example of atypical is COVID-19. COVID-19 is atypical viral pneumonia because it is caused by viral, bacterial, fungi, viral, and aspiration pneumonia. This is viral pneumonia. PCP is a fungal pneumonia. Streptococcus is bacterial pneumonia. Toxoplasma is a parasitic, right? So likewise, so sudden onset, atypical gradual onset, productive cough, non-productive cough. They usually have high fever. They do not have much high fever. Usually they have low fever or minimal fever. Like viral infection, we see the viral infection. They have low grade. They are not having cough, gradual. Evidence of local signs, minimal local sign. What do you mean by evidence of local sign? Means in the lung you may have crepitations, you may have some crackling, right? You may have pruritus, pruritic chest pains, shortness of breath because of cough, empyema, pleural effusion. So local signs are there, which is usually not there. Myalgia and headache are uncommon, which is very common. Focal, alveolar, or lobar infiltrate on chest X-ray. Diffuse interstitial infiltrate in the chest like COVID-19. Diffuse infiltrate. Leukocytosis like high WBC count, white cell count are high. They are usually uncommon or many a times it is normal. Is that clear to everyone? Yes or no?
Yes, sir.
Yes, sir.
Wonder, wonderful. So this will help you clinically. So whenever patient comes to you, look at the fever, look at the time duration, look at the sputum, look at the X-ray, look at the local sign, and look at the WBC count, look at the chest X-ray, and then you can differentiate by this point only. Before doing culture will come, you can say, oh, this is looks like a typical, this is looks like atypical, because you have X-ray, you have symptoms, you have onset, progression, CBC, everything you have it now. Legionella. The answer for this is atypical is Legionella. Legionella. What is Legionella? Let's go to the Legionella. So Legionella pneumonia, also known as Legionella disease, is a severe form of pneumonia caused by Legionella bacteria, often from inhaling contaminated aerosolized water. Symptoms include fever, cough, shortness of breath, muscle ache, gastrointestinal issues, or diarrhea with cramps with 2 to 10 days incubation period. Diagnostic required specific test and early treatment with antibiotic like azithromycin or fluoroquinolones is a crucial for recovery. So this is Legionella, right? So this the answer for this is what they are asking is atypical. Atypical is Legionella. Rest of the things are typical. What is Legionella? We told you what is typical versus atypical. I told you. So I'm not going much in detail of all this blah blah. So I already told you, explained you, right? Last one or two questions, then we'll have a quick feedback. 45-year-old woman with unexpected weight loss, loss of appetite, shortness of breath present to your clinic on examination. There is reduced air entry and the dullness to the percussion on the right lung. A pleural tap is performed and aspirate sample sent for analysis. You are told that the results reveals a protein content of more than 30 gram per liter. From the below, select the most likely diagnosis: bronchogenic carcinoma, congestive heart failure, liver cirrhosis, nephrotic syndrome, MAKE syndrome, or bronchogenic carcinoma. So now you have
A,
to have
A.
little knowledge of transudate versus exudate. So can anyone tell me what is transudate, what is exudate, what is the LDH and protein in exudate, transudate, and what are the example of transudate and exudate? Fine, fair enough. So this is the chart for you. I always come up with the excellent chart. My lecture is packed jam with the charts and these pictures. I love it. So it's a lights criteria for pleural effusion, transudate and exudate. So exudate, right? So exudate, they have protein. So you need to monitor two protein. One is from pleural fluid, one is from blood or serum. So pleural protein divided by serum protein, if it is more than 0.5, it is exudate. LDH same way. Pleural LDH, you do the pleural tapping, you send the protein and LDH. See the protein versus serum. So pleural versus serum, here pleural versus serum, same. But here protein and LDH. Even though LDH is also high, protein is also high. That means it is exudate. If it is low, it is transudate, right? And what are the example of exudate is, right? Is the infection, right? Infections and malignancy, right? Both will secrete high amount of exudate or amount of protein and these things from the cavity, in the cavity, so they are high. So LDH and this protein is high. So infection and malignancy, third is pulmonary embolism. But at least remember infection and malignancy. So whenever you see infection, whenever you see malignancy or cancer, it is a until proved otherwise CA. How you supposed to confirm? By sending the serum, sorry, pleural versus serum protein and LDH. If it is more than 0.5, 0.6, this is how you can know. This is a simple lights criteria. So you always keep in mind, because we have many pleural effusion in our OPD and your OPD, right? Tuberculosis effusion, pleural effusion could be cardiac pleural effusion, pneumonia pleural effusion. You may have malignancy pleural effusion or CA lung pleural. You have mesothelioma. You have systemic disease or you have autoimmune disease, right? So there are a lot of things, right, which have pleural effusion. So best test for any pleural effusion is to send cell count cytology and measure the serum and pleural protein and LDH. So 90% of your job is done. And if you allow me, I will ask one more question. I'll jump to this 11. I have many questions of respiratory, though it's not completely covered, but I covered major topic. But one more lecture, I think it's needed to cover major topics of respiratory system. So last questions for today. A 4-year-old boy with a history of moderate persistent asthma present to the emergency department in severe respiratory distress. At home, he has been experiencing rhinorrhea, cough, followed by visible difficulty with breathing. His symptoms have not improved despite albuterol treatment every 4 hours. He is currently febrile. His heart rate is 128 per minute. Respiratory rate is 42 per minute. His blood pressure is 102 by 53. His oxygen saturation is 94%. Will while he breathes ambient air, air exchange is fair in the lung fields, means bilateral equal air entry reasonably. Inspiration and expiration produce minimal wheezing. Treatment with oxygen bronchodilator systemic glucocorticosteroid is initiated. 20 minutes later, the patient remains tachypneic with labored breathing. Which of the following additional finding would be the most worrisome, most dangerous, bad prognosis in this patient, right? So this patient scenario is with you. So what is bad? What is worrisome? He develops intercostal and supraclavicular retraction is worrisome. His heart rate increasing to 185 beats per minute is worrisome. His oxygen saturation falls to 89 is worrisome. His respiratory rate increased to 62 breath per minute is worrisome. Or his chest examination no longer reveals wheezing is worrisome. Take your own time. Don't forget my triad diagnosis, investigation, treatment. So, what's the diagnosis? You just make some diagnosis in your mind, and they are asking what is the worrisome now in this patient. Yes, what is worrisome in this patient? So don't expect one line question in exam. I don't want to disappoint you. I don't want to scare you. But this is how you have to practice every day. Don't need to mug up the answer. You need to understand complete scenario, and it is absolutely scenario based exam nowadays. You never ever get one liner. What is the treatment of choice for cardiac failure? Nothing like that. Long scenario. This is long scenario. So what is the diagnosis here? Can anyone tell me? Can anyone tell me what is the diagnosis
Exacerbation
here?
asthma, sir.
Sorry.
Life-threatening severe asthma.
Okay, fine. Fair enough. So it's a bad severe asthma. Okay, fine. So now patient, everything is in front of you. If you have any question, you can ask me from the scenario if you don't understand. Otherwise, everything is clear cut. So what do you think? Having which of the A, B, C, D, E is worrisome in this patient? Having with this, you are more worried. Oh, this patient will going to complicate or die, this baby. What is that? I did not discuss very toxic questions or very complicated. I have hundreds of toxic questions, but you will not happy on me. That is why I'm trying to go gradually the severe questions, little easy, then more complex, and very complex. So this is little complex where you need to apply the clinical knowledge. I stepped up gradually from low, intermediate to more complex. This is little complex, not more complex. Yes, anyone?
Yes, sir. I'll go with
Yes, sir.
option C.
Option C is oxygen saturation falls to 89. Okay, fine, fair enough.
Option E.
Excellent. Another option is option E. So let me understand from you, doctor, why option E? It is the correct answer. Option E is the correct answer, but I want to understand. His chest examination is no longer reveals wheezing. So no wheezing means what? Patient is not improving.
That means
Patient
that's
still
what I
remain the
thought.
tachypneic and labored breathing patient. After 20 minutes, they started everything. They started oxygen, they started bronchodilator, they started systemic glucocorticoids, and after 20 minutes of this all started, still patient is tachypneic and labored breathing, and his chest is no longer reveals wheezing. So there are two options whether it is getting better, which is less likely. Why? Because patient clinical condition is deteriorated, so is not better, and there is a complete bronchospasm, and because of that, no wheezing, complete bronchospasm, severe state of asthma, severe, very severe. So wheezing is good, no wheezing is bad in asthma. So if no wheezing, there are two possibility: patient improved, patient not improved. So patient improved and no breathing, wheezing, it's a good sign. Drug is acting, salbutamol or beta 2 agonist is acting, but patient is worsening after giving all bronchodilator, oxygen, glucocorticoid, and patient is deteriorating and no wheezing is the worst sign, means bronchus is completely blocked, right? So this patient may die. If you don't attend these patients well, this patient may die. Where is that question? Okay, fine. So right? So this is, yeah, sorry, I missed the question. Yeah, so this was the question, right? So what is the explanation? Answer is his chest examination no longer reveals phase. Patient with severe respiratory distress must promptly distinguish from the impending respiratory failure, right? In patient with asthma, wheezing occurs because of airway obstruction. It is heard at the end of expiration when asthma is mild, right? And occurs with inspiration and expiration when patient is in respiratory distress is more severe. The absence of wheezing in a child with respiratory distress suggests inadequate air exchange, potentially respiratory failure, and blah blah. That's it. So, and why not other options? So we have seen the answer, but why not other options? For those who answer A, B, C, D, let's check very quickly on that as well, one by one. So he develops intercostal and supraclavicular retraction is not the answer. It could be many other reason. Worsening tachypnea, tachycardia, presence of intercostal and supraclavicular retraction, and moderate hypoxia, oxygen saturation percentage is mild to moderate high would be indicative of respiratory distress, but would not be as worrisome as wheezing is absent. It is worrisome, but not, you have to have priority. Na? So this is least priority. Heart rate is 180 per minute. Worsening tachycardia, tachypnea, in the presence of intercostal supraclavicular retraction to moderate hypoxia would be each indicate respiratory distress, but it would not be as worrisome as wheezing, absence of wheezing, right? Which was initially wheezing was present, now it is absent, so it is more severe asthma, right? Oxygen saturation, somebody told, so oxygen saturation is also worrisome, but not as like, so worsening tachycardia, tachypnea in presence of intercostal supraclavicular retraction, moderate hypoxia would each indicate respiratory distress, but not as worrisome as wheeze, which was present initially on the patient, and this increased respiratory rate, the same explanation. So that's all from my side today. So this is what the more worrisome. So go and read the asthma. This is right. So this is homework. I had given you couple of homeworks. Don't hesitate to do homework, asthma, right? What you need to know, we'll discuss in next couple of lectures. Definition, classification, mild, moderate, severe. How the pulmonary peak expiratory flow or pulmonary function test effect on each asthma, right? What is the treatment and how is the prevention? Is there any vaccine for asthma? These are the common frequently asked questions. So completely rectify this asthma, right? So there are lots of hundreds of questions on asthma. We'll discuss couple of questions in the next lecture. So thank you very much once again all for joining me today and listening me coolly and calmly. So before I end up my session, I would like to have very quick feedback on the people or doctors who joined the first time. How did they enjoy it? Like I enjoyed a lot. How you enjoy? What was the learning? I would like to listen from the new candidate who joined the first time. We have many students who already in the coaching and they listen me many a times. So I want to know what's your experience before and after the class.
So this is a very excellent class, sir. And I have gathered many take-home points from your lecture. Thank you so much,
Wonderful.
sir.
Wonderful. So I think you just try to improve the way you read, right? Something would be the take home from my side, right? So implement it
Yes,
on
sir.
daily practice. Don't need to mug up the things, right? Try to understand. Though you solve 20, 30 questions, 40 questions a day, but the quality should be 200 question a day. Today we discuss only 10, 12 question, but in 12 question we clarify the concept of 50 questions. You understand why this not,
Yes,
what
sir.
is atypical, what is typical. We had many things in our mind, but we don't know the concept, so we need to build up the concept. Thank you very much for your name is Dr. Bright, right?
No, sir, I'm Dr. Saranya.
Sarani, oh sorry, yeah, sorry. Yes, fair enough, keep in touch. Yeah, anyone else who joined the first time, I would like to have a quick
Yeah,
genuine
it's good,
feedback.
sir.
How you?
Yeah, it's good, sir.
Okay,
It's good and very clearly explained, sir. Thank you.
wonderful. So we need to
A
do it
lots
in
of
such a
explain for each option, sir. It's good, sir.
wonderful, wonderful.
Sir, thank you
And
so much. This is the first time I've listened to your online classes. I was always bad at pulmonology, but you have cleared many of my concepts today.
Wonderful. So keep joining every Sunday. This Sunday is a mega mock test, so try to attend or solve in 24 hours of time and try to be eligible for gift as well, just to motivate you. Yes.
Okay, sir. Thank you so much.
Thank you,
Anyone?
sir.
Wonderful. Anyone last? Any comment? Old
So this
students?
is Dr. Lalita.
Yes, Lalita.
So I'm very happy to tell you that I have recently passed my DHA exam. Yesterday I got
Wonderful.
my
Very
result,
glad.
and
Wonderful.
this was my second attempt. And to people all present here, I'll just tell you only one thing, that I prepared only through Dr. Munjal sir's classes and the MCQs which are there in the application. I have practiced it many a times, and I would just advise you that do not miss the classes. This 1 hour session is a very critical thing where we can gain a lot of knowledge. But the thing is, before the class, just have a reading from the applications. Try to solve the applications and gain the knowledge, so that while the class is going on, it will be a reinforcement session. And actually, I had a career break, and I was very much low in confidence. But Dr. Munjal Pandya sir, always he had faith in me, and his words were very much inspiring and very much motivating. And I just thank you a lot, sir. I'm very much grateful for you, because
No,
I was
no,
very
it's
much
my
scared because
pleasure.
of my second attempt.
No, no, my pleasure, doctor. Everything you did it. I didn't did anything. It's all your hard work, commitment, and your this completely tireless efforts will make you, I mean, successful. So I'm just pushing you guys. That's it.
No, sir. Today itself, in your class, three questions came in my exam also, sir, regarding that this methacholine test and transudate. Regarding
Wo-
transudate and adenocarcinoma, I had questions in my exam. And
Wonderful.
this time, it was not, most of the questions were case scenario based, sir. One-liners were very minimal, and
Yes, that
I
is
was
what I
able to
told.
crack because of your classes only, sir. Yours and all the faculty members, they helped me a lot with
Thank you very
understanding the
much.
concepts.
Thank you,
This is true,
Lalita.
sir. What you say is true. Your class is purely a conceptual class. It's not mugging up and all. I applied all the knowledge which you taught me, and with that aspect, I applied, and thank God I cracked my exam.
Very glad to hear you cracked it. Thank you very much. Yes, last
Thank you,
but
sir.
not the least, anyone. Yes, anyone. Then we'll pack up. Dr. Asim Hanifa, I think you also joined first time. Yes, anyone else? Lastly, from our class, something learned new. Rahima, Asma, Anisha, Azmat, MD Shadab,
Yeah, hello.
Rosni. Yes, yes, Ishara, Jahabar, Murad, our old players.
Thank you, sir. Yeah, it's good, sir, because a lots of explanations for each option, sir.
Wonderful. Fine. Thank you very much all for joining today. Keep in touch and you can post your feedback in the group as well. Thank you very much, and I will keep you updated my classes once again in the group. So look at my message. I never say any bogus message to anyone. I'll just if my message is in your Dropbox or your message, it's important. That's it. I never say good morning, good night, hello, hi, hello. I mean, it's all absolutely learning. Thank you very much once again, and see you next week. Thank you.
Yes, sir.